Welcome, everyone. My name is Betsy Underhill. I'm the marketing director at Mountain Valley, and welcome to Embracing the Counterculture, how ERP and OT can work together to help patients face their anxiety head on, presented by Mountain Valley's Executive Program Director, Zack Schafer, and Mountain Valley's Clinical Director, Tim DiGiacomo. Just quickly, we are offering CEUs for this 1-hour webinar. And after the completion of the webinar, everyone in attendance will receive an email with instructions on how to obtain your certificate. We'll also have the opportunity for Q&A at the end of the presentation, and we're using the Q&A function to ask questions. So with that, I'm going to turn it over to Zack and Tim.
All right. Thanks, everyone, for being here today. We really appreciate you signing on and learning about some of the work that we're doing, especially as it relates to ERP and occupational therapy. So we wanted to kick it off with a bit of information about exposure response prevention. ERP is really the gold standard in the treatment of anxiety and OCD. It's based on CBT, the cognitive behavioral therapy approaches, with a bigger emphasis on the B, so the behavioral piece. And ERP really focuses on helping clients to engage with and get exposed to the things that provoke anxiety and fear and distress for them. It's also about reducing or discontinuing the things that they're doing that are actually, in a sense, maintaining the anxiety. So reducing avoidance, reducing what we call family accommodation, like when family members or friends or others do things for someone with anxiety that really they probably can do themselves. They just haven't had the opportunity to, or they're too afraid to, because the fear is just, it's so uncomfortable. It's so unpleasant. And really ERP is about learning to have a different kind of relationship with the things, the situations, people, places that create that distress for you. And so there's a few different types of exposure categories. The first we'll refer to as interoceptive, and I think Zach's going to talk a little bit about this as we get in, maybe jump in now as well, in terms of how that ties into some of the occupational therapy aspects of what we do. But interoceptive is really about engaging with the physical things that actually make you feel uncomfortable. So, for example, if someone presents with panic disorder, right, or they're experiencing high levels of panic, or their anxiety is, they feel it in their body so much to the point that it's uncomfortable, we can help someone recreate those feelings in a way such that they can get more acclimated to it, or so that they can learn, that they can understand how to cope with that and how to be with that. So, for example, some of the physiological symptoms of anxiety are, one is dizziness. All right. We can recreate dizziness by spinning around in a spinny chair, right, until someone gets dizzy. Oftentimes when people are experiencing panic, their heart rate increases. We can make that happen. Someone can, do high knees and be jumping around for a while until they get their heart rate up. Starting to feel lightheaded. You can have someone hyperventilate intentionally to recreate that feeling. And, if for those of you out there who are sort of new to this approach, it may seem a bit like torturous. And I think that's where we were coming at it from, this idea of counterculture. Because it sounds like, well, wait a minute, you want me to go to therapy so that I can feel even more uncomfortable? And yes and no, right? Because yes, we want you to feel uncomfortable so that you can then change your relationship with that. So you can start to interpret that when your heart races, it doesn't necessarily mean that you're going to have a panic attack, right? Or so that when you start to feel sweaty or dizzy or start to have a hard time breathing, that doesn't mean you're having a heart attack, right? It might just mean that's your anxiety playing out. There's imaginal exposures, which is exactly what it says it is. So you're actually imagining that which provokes anxiety for you. You're imagining yourself gradually getting closer to being in that situation, right? And then the in vivo is actually in real life. So these are exposures where in real life you are actually engaging with the thing that creates distress for you. Zach, anything you want to add on that?
No, I was going to say, I think the interoceptive component, there's also ways in which we can do it. We can incorporate those physical sensations in a way that is relatable to functional activities as well, right? So it's not just we're going to sit you in a chair and spin you around till you get dizzy, but can we actually get you to engage in a game of basketball? Can we get you to engage in something that's actually going to challenge your vestibular system and elicit that? But it's also purposeful. It's also meaningful. It has the activity and the exposure has more meaning and more relevance rather than sort of just isolating specifically on the experience. How can we generalize this to why it's important for you to be able to experience these things so you can do a wider range of activities in your life? And it's not too much different than sensory integration treatments for a lot of kids too, as well, where a lot of people think, oh, I have this sensory sensitivity, what can I do to sort of avoid that sensation? But our system's never going to learn how to properly integrate that sensory information if you aren't exposed to it underneath conditions that you can manage and handle. So it really aligns a lot with some of the OT theory around sensory integration. And actually, it's not to avoid those sensations that make you feel uncomfortable. It's let's introduce those sensations that make you feel uncomfortable within a context, within an activity, within an environment that makes you feel safe enough to approach that.
Yeah, and I think the other tie in there, I think oftentimes when people are approaching exposure work, and to go back to that idea of you're spinning in a chair as an interoceptive to create dizziness, because that may be what someone is experiencing when they're in a panic state, right? And so, I think it's easy for a mental health clinician to frame it in that way of, well, we're working on your panic, right? But I think once you start looking at it from that broader lens of, well, what else are we working on here? But we're working on you living the life that you find meaningful and valuable. So, if part of the reason why you're not going out and playing basketball is because you're afraid you're going to have a panic attack, well, part of it is, yeah, if you're going up and you're playing with your friend and you're jumping around, you might start to feel dizzy. You're going to have a panic attack. But just broadening that idea, and I think that's where the OT really comes in. It helps. I think there's a good synergy between both fields here. So how ERP works. Exposure therapy isn't really about why someone is experiencing abnormal anxiety. It's just that they are, right? And the why can be helpful more in terms of just trying to understand how to better design exposure work around it. But it's different than sort of the traditional insight-oriented therapies, or just sort of open-ended process types of therapy. It's very action-based, it's very behavioral. It's just figuring out where is the distress, where is the anxiety, and then how do we engage with it, right? It's also about figuring out what are the person's safety-seeking behaviors. What are the things that they're doing to try to cope, but that's actually not helpful for them, because the way that they're doing it is actually robbing them of an opportunity to see that they can be in those stressful situations, right? And ERP is really about disrupting the patterns of maladaptive coping and avoidance, and put in place a more healthy, adaptive approach that's focused on engagement rather than avoidance. This is something that we teach to our residents and to the parents of our residents here at Mountain Valley. The anxiety and OCD maintenance cycle. I think this is something that you all can use if you're working with clients, or for yourself, or for your kids, or for others that you know. But you can apply this to broadly any situation related to any type of anxiety, or sort of any sort of OCD symptom, whatever the obsession is. So you have your fear cue, you have a misperception of danger, right? And really that's the overestimation of danger and the underestimation of your ability to cope there. moves down to a maladaptive coping response, which is often some sort of avoidance, right? Or when we're talking about family systems work, we're talking about accommodation, right? What is it that others in a person's orbit are doing that is trying to be helpful and reduces anxiety in the moment, but actually keeps the anxiety going, right? So if you avoid, or if you've been overly accommodated, what ends up happening is you lose that opportunity to see that you could actually be in that situation. What ends up happening then is you end up with that heightened sensitivity to fear, whatever the fear cue is, whatever the trigger is, and your anxiety either increases or at best it just stays the same. And then it goes back to, again, once you're back in that fear situation, kind of repeats the cycle until you start to introduce something like ERP, some occupational therapy components, and it gives you a chance to start removing the maladaptive coping and instead inserting more engagement. So while we're doing exposure work in sort of a very traditional sense, and again, this is something that we teach all of our clients here, we incorporate what's called the PsyD scale, so the subjective units of distress or discomfort. And so you can also use this, even throughout your day, just sort of noticing it as a bit of a mood tracker, right? But when you're doing an exposure, you want to get a sense of beforehand, what is someone experiencing? Are they at a 0 or a 10, or 0 to 100, whatever your scale you would like to choose. But 0 would be really being completely relaxed. So 0 distress, incredibly calm, right? A 10 would be like full on panic, the worst feelings ever, right? And so while you're doing exposure work, where I find this to be helpful is it can help bring awareness to what one is experiencing, and also help to give a real descriptor and start to differentiate and notice. So as I started out in this exposure, my anticipatory anxiety was really high, right? I was like an 8, and I didn't think I could do it. But then as I jumped into it and I started doing it and I sat with it and I started to engage with the thing that created the fear, and I started to notice, well, it went up a little bit and then it started to go down a little bit. And then maybe it went up again, and then maybe it started to go down as I stayed in it, as I didn't avoid, and as I changed my relationship with it. Anything to add, Zach?
No, I don't think I have anything to add to this one. I mean, I'll talk a little bit about how SUD sort of fit into the OT stuff once we get there.
Excellent. And the next few slides, we just wanted to give you a sense of what our exposure work orders look like. So with cognitive behavioral therapy and with ERP included, we think it's helpful to do it, together with your clinician. It's also helpful to be generalizing this work and doing it more as assignments, as homework, and outside of just your therapy hour a week or whatever you're doing. If you're in a particular program. The idea is you really want to make this a lifestyle. And so what we teach our residents here and our families is how to do exposure work, moving to a place of being able to do it independently. So we start with an ERP work order, a work assignment, and this is a collaborative approach. The idea is that this is any sort of exposure work that you're doing. It's not just, well, I'm doing this because my therapist told me I need to do it or I should do it, right? That shouldn't be the reason we do all these, these hard things. We should have a real reason to do it. So we come up with it together. We identify what is the feared outcome of the exposure. And this is where you'll see some of the more traditional cognitive behavioral therapy concepts come in, things like cognitive distortions, or, again, that idea, that overestimation of danger and threat. So what do you expect to happen? Sort of like, what's the worst case scenario? Oftentimes when people are early on in treatment, that's what they jump to, that worst case scenario. How high do you expect your anxiety or discomfort to get? Oftentimes, again, early on, people are thinking it's going to get to, a 10, full on panic. I won't be able to do this, right? What are your turning away or safety behaviors? These are subtle things or very overt things that, things that we all do to try to manage anxiety. But really, when you're doing exposure work, you want someone to really lean in to the discomfort. You want someone to really essentially want what they don't want. Or it's some of that kind of saying, get comfortable with being uncomfortable, right? So really leaning in here. And if you are doing this with someone else, it's how will you or someone else know if you're avoiding? Or in the case of OCD, how will someone else and how will you know if you're engaging in some sort of ritual? And that could be something, again, that's overt and that we could see, but that could also be more of like a mental or an internal ritual, right? And the idea here is this is really about accountability to oneself and to the ERP work, right? Not shame if you're engaging in some sort of avoidance or some sort of ritualizing. But if you are, it just speaks to how challenging it is, right? And it speaks to maybe you need some additional support as you're going through this. So again, turning towards what will you do instead? How will you intentionally lean into this, right? And what can others around you do to support you while you're doing that? And how willing are you to do this exposure? So again, this goes back to what I said earlier. We shouldn't be doing things just because a therapist, tells us to do it, right? Or at least if that's how it starts, okay, but it shouldn't have to stay that way. Zack and I talk more about what's a valued life, what's a meaningful life. I always want the people that I work with to be deciding on doing something because it's of value to them, right? Because they see an importance to them in their life. And how is it moving you toward what's important to you? There's, in acceptance and commitment therapy, which you can also incorporate into exposure work, is an exercise called the choice point exercise. And the idea is, essentially once you hit one of those times of struggle, right, you can make two choices. One is to move towards your values and what's important to you. One is you move away from your values, right? And so again, are you going to lean into it, and say, I'm going to experience whatever comes at me because I still believe it's important and it's in line with my values? Or are you going to say, I can't do it. I'm going to back down. So while you're doing an exposure, again, in a very traditional sense, every few minutes you're wanting to get a sense of what is your change in SUDS. And again, where I think this is helpful is just increasing someone's awareness of how they're feeling. And sometimes it can give a chance to see that your anxiety is going to peak and then eventually it will go down. Also, if you're, that doesn't always happen in terms of this idea of habituation, but it can, and it's helpful. And then afterwards, so, some of the exposure work that we were doing earlier this morning in our ERP group, it's not just doing the exposure and then you're done. Oftentimes there's a lasting effect to doing exposure work, and it can be a mix of experiences. So for some people doing it, they may experience some pride for having done something that was really challenging for them. For others, they're still feeling the effects of, I pushed back on I didn't do a compulsion, and now I'm still getting these intrusive, unwanted, or obsessional thoughts, or I'm still very worried, right? So that anxiety can hang on, but you still want to get it. And so that's why you want to check in afterwards. You want to get a sense of, well, did the feared outcome happen? If it did, how are you coping with it? How are you working through it? How are you sitting with it and experiencing it? If it didn't happen, what happened instead? And this is sometimes where you'll see people say, well, I anticipated that the exposure was going to lead in this direction, and it actually didn't. The worst case scenario didn't happen, or the worst case scenario did happen, and I was able to get through it, right? And I feel stronger for it. What did you notice during the exposure? So in a traditional CBT sense, what were the thoughts, feelings, and behaviors that you picked up on, right? How did those influence what you did while you were in the exposure? And then what did you learn, right? So oftentimes, at least, the people with whom we work, they've been avoiding for so long that once they start engaging in exposure work and the therapeutic programming that we're doing, it gives them a chance to kind of really get outside their comfort zone, and see, what's different, because the usual for a lot of them is avoidance, right? So we wanted to put down some basic examples of exposure work, just so you'd have some context for it. So, social anxiety is something that is very common. We see a lot of people present with this. There's really this fear of judgment from others. What are some types of exposures to get at some of this? And again, all of this would be gradual. So public speaking, right? If on day one of exposure work, we said, well, we're going to have you read a speech in front of 200 people, right? Or we're going to have you do a webinar on exposure work and occupational therapy. And we know you're really nervous about that, right? That would probably be too much. That would not be a great place to start. But helping someone to do some imaginal work about, imagine yourself giving a talk to 5 people that you know, right? How about the 10 people that you don't know? And then actually moving into actually doing a talk, like giving a presentation in front of others, and sometimes with support and then sometimes without support. And you can gradually increase or decrease the anticipated level of difficulty and challenge as needed. For some kids who get very anxious in class, it could be as simple, for some people it's to raise your hand in class and ask a question or give an answer. Some people that's very easy. For other kids that's terrifying, because it's, well, what if I raise my hand and what are people going to think of me? Or what if I answer wrong? What if I raise it and I seem really confident and then I get the wrong answer and everybody's going to think, oh man, that guy's so arrogant, he doesn't know anything, right? So again, that fear of judgment. Ordering food at a restaurant, eating in public, doing something embarrassing. I wrote participating in an improv class, which actually there are improv groups throughout the country now that have picked up on the idea that there's a lot of social anxiety out there. And, if they partner with therapists and use improv, that's a great way of doing exposure work, right? Some additional examples, if you're thinking of some of the various subtypes of obsessive compulsive disorder, there's scrupulosity, which is very focused on morality or potentially offending God. So exposures for that could be writing out a quote blasphemous statement and not praying afterwards, not seeking forgiveness afterwards. I think most people are pretty familiar with the idea of contamination OCD. So this would mean intentionally touching something that would be, quote, contaminated, right, or dirty, and then not washing your hands afterwards, or washing your hands afterwards, but then recontaminating with something else, right? Just right OCD. This kind of ties in with this perfectionism, or things have to be just a certain way. So this would actually be doing something that would be incomplete. And we see this oftentimes with high school and college students who, for a lot of their life, they've been praised so much for doing the perfect job, in their writing assignments. Well, that's fine until they run up to deadlines and they can't turn things in because it's not just right, because it's not perfect, because it still feels incomplete to them. That's an exposure, having a deadline and still turning it in and being open to whatever happens next. OCD related to checking, you could do things like, we'll check once and then don't check again, right? And then kind of move on. That's incredibly hard for people. If someone's obsessional, intrusive, unwanted thought is that they left the stove on, right? And they walk out the door and then they walk back in the house and they walk out and they walk back in and they're checking each time. That's an incredibly scary kind of exposure to do, to say, well, you're just going to check once, right? And there's a reason for it so that you can get out the door and out to work and bring your kids to school and do whatever you got to do. But it's scary, right? And then to also refrain from reassurance seeking. So did I do it? Did I do it right? Did I do it? Should I check again? Do you think it's going to be okay? Right? And that's where that accommodation piece comes in when we're talking about exposure work.
Yeah, now it's my turn to talk a little bit about OT and sort of talk about how we can supercharge some of the ERP process through occupational therapy based concepts. I figured some people out there may not be totally familiar with OT and sort of how it fits into the whole mental health space. And this is one of the more famous quotes in our profession. The man, through the use of his hands, as they are energized by his mind and will, can influence the state of his own health. And it was actually a psychiatrist who was at Shepherd Pratt at the time in the early 1900s, who recognized the healing power of engaging in activity, and that engaging somebody meaningfully and occupying them, that's sort of where the name comes from, can have these inherent impacts on the individual where their symptoms start to dissipate, or it becomes an outlet for them to actually work on their symptoms in a way that's functional, meaningful, and valuable to what they would like to contribute to society. Next slide, please. So in OT, participation in meaningful activity is both a means and an end to the therapeutic process. So the goal of OT is to always help you be able to function better in the everyday activities that you want and need to do. And we also use activities as a means to get there. So the activity is both the intervention and the outcome that we're aiming for. So talking a little bit about OT's role at Mountain Valley, as the executive program director and as an OT, there's sort of this macro level intervention that I get to have with the OT lens. And that really comes into milieu design. So in occupational therapy, we sort of acknowledge all these different areas of occupation. Essentially, if you were to take anything that you did throughout the day, it would fall into one of these different areas on this colorful wheel over here. And really what we sort of do with OT here is we use activities to elicit certain skills and experiences. So we can use activities to elicit exposure opportunities. So we have kids who are socially anxious, and speaking up is a big challenge for them. We can do an activity that will naturally require that sort of speaking up in order to be able to engage in it. Or you could play a game where speaking up and sort of giving other people feedback is required in order to actually play the game. So you can build in the skills that you want to work on and the exposure experiences you want to work on into an activity, and sort of hide it in plain sight in a way to help individuals work on it. We talk a lot here about it's kind of like applied psychotherapy. You're sitting in the office, you're learning all these things about your fears, you're learning about your values and who you want to be, you're learning about your communication style and how it might be more effective. But then you actually have to go out into the world and apply it. And that this is where being in a residential setting and setting up a milieu structure in which a kid can go into their therapy office and sort of dive into some of their anxiety and dive into some of what they want to work on and some of the fears they want to work on, and then have a place and a playground to sort of then go out into and then enact some of those changes and apply those insights into actual tangible behavioral changes and ways in which you're engaging with your life. And the other piece too is, and this is where I was going to touch on that SUD scale a little bit, is we also want to set up activities that foster mastery, connection, and restoration, and other sort of positive experiences as well. We do not want you to be in a constant fear state. It's not healthy to be in a SUD scale at a 10 all the time. And it can actually be really helpful when you do match a fear with a really meaningful, purposeful activity, that both can exist at the same time. And the kid can be learning, like, I can have a SUDS at 10 and feel really accomplished by participating in the activity, or I can have a SUDS at a 10 and feel a lot of distress while also feeling a lot of connection to my peers at the same time. And sometimes by pairing the fear with another positive experience, not in a way that's a safety behavior, in a way that's decreasing the distress, but in a way that it's complementing the distress and provides an additional motivation, reason to engage. That's sort of where some of the OT lens can really come in. The other really important sorry.
No, go ahead, Zach.
Yeah, that's okay. So the context and environment is super important as well. So from an OT lens, we're always considering what is the context and environment in which these activities are happening, and how do we sort of set up social cultural norms and shared values and beliefs that can help reinforce some of the behaviors that we want to see, right? So if you're trying to teach a kid that embracing discomfort is good for my health, it's actually good for my well-being to step into positive stress, because stress actually creates adaptation and it creates a better version of me. We need to have a whole community of people who also believe in that concept. That's where that counterculture concept comes in that Mountain Valley, we have our own culture that is a little bit different than the grander society right now, who's sort of saying, watch out for trigger warnings, watch out for feelings of distress. Those are the things that you should be avoided, or the environment around you should sort of be changing to fit your individual needs. And as nice as that sounds, sometimes it's really just not practical. And so here we get to create a community where it's actually okay to trigger one another. It's okay for other people to have different points of views and different things like that. And for us to help the kids develop this mindset of these emotional responses are good for me. My emotions they're there for a reason. They're there to help guide me and teach me if I can lean further into them and learn how to feel them. The other important piece to context environment too is thinking about the context and environment of certain exposure work that we do, and how do we create sort of a safe space for that. If you're really trying to dial in on a fear, you kind of want to get rid of some of the other things that could keep the person from engaging in that exposure. So who are the people that make them feel a little bit more comfortable to approach that peer? What's the physical space that might help them do that? And also creating a physical space that would cause some of those exposure experiences to naturally come up, right? So an environment that's not perfect. So Mountain Valley is an old it's beautiful historic campus, but it's old and it's not new and it's not squeaky clean, and there's some dust in some places and there's some dirt in some places, and we live on a farm, and all of that can really help get at some of the stuff that our kids come here to work on. And then the final piece is really just that routine and structure. Really trying to set up a routine and structure here that's developmentally appropriate for the kids and directly transferable to their next environment. So kids come often because they're having a difficulty time engaging in what they want and need to do. And at that age in their life, it's school. So what do? We set up our structure here in our Milieu schedule to match what a school day looks like. So when they're going through their different exposure experiences, or I don't want to go to this next group, or I don't want to go to this next thing, it's, well, you also might have that math class that you don't want to go to, or you might also have that science class that you don't want to go to, or that you're fearful of what that teacher might say, or you're fearful of that classmate that's going to be in your class. And how do we set up the structure here to match the structure that kids are used to participating in and they're going to have to participate in once they leave? So when we're doing that exposure work, it's really transferable. So in addition to sort of me in my position designing the program from a larger aspect, there's also the micro level OT, and I still have the privilege of getting to do some individual interventions with some kids. And then we have an occupational therapist who's very much immersed within our milieu to really help provide that in the moment sort of support. So beyond just providing that in the moment support, our OTs at a micro level really help here with evaluation and activity analysis. And we're going to get to this on a little bit of a slide a little bit further down, but from an ERP approach, it's very much bottom up. Like, what's the fear and how is that impacting your ability to engage? Whereas OT is very much top down. What are you trying to engage in? And now let's break it down to what's actually the problem and where is that coming from? And sometimes that can be really helpful in really getting specific about what is the dysfunction here. Like, is it actually anxiety? Is it actually this fear? Or is it more of an actual cognitive limitation or some neurodiversity that might be going on, or some more sensory processing issue that's going on neurologically within the system? So really being able to look at the activity and look at engagement and break the problem down in the case conceptualization from that top-down approach can really complement the ERP process really well. We're really good at looking at activity analysis. So what exactly does it take in order to engage in an activity? And you'd be really, really surprised about how complex the human system is just to do simple things like brushing your teeth or taking a shower. There's so much going on from a sensory motor standpoint, from a cognitive standpoint, from an experiential standpoint. To really be able to break a lot of those things down can be really helpful for kids to sort of be able to learn and understand about themselves and their engagement, and really helpful for clinicians to understand where the barrier is. Our OTs here also provide a lot of psychoeducation, mainly around like anatomy, physiology, neurobiology, really getting into like what is the chemical process of emotions, what are they there for, why do they exist, how does your nervous system work, what is this sort of sympathetic arousal system that I experience, and a lot of psychoeducation around lifestyle factors too. Anxiety and OCD and anxiety-related disorders don't happen in a box. They happen within a life. And how does your sleep impact your anxiety? How does your nutrition impact your anxiety? How does your exercise routine and your engagement with fitness and other things along those lines? All of that, really taking that big holistic picture into sort of lifestyle medicine. That's a lot of the psychoeducation that we provide as occupational therapists as well. And then we are very much, this is where ERP and OT really overline. We're very much a doing profession. It's very much about engagement. So activity participation, and we engage kids in activities for an abundance of different reasons here. One of them is that sort of skill building and experiential learning. That other part is sort of experiential healing, though, because there's certain activities that you can engage in that are really naturally healing for your body and mind. And that's going to be different for every kid. For some kid, that's knitting and crocheting. For other kids, that's going on a trail run or going on a mountain bike ride. For other kids, it's playing D&D or playing some sort of board game or doing mind games like puzzles and Sudoku and different things along those lines that really just seem to have a nice healing effect. And again, we don't want our kids to always be in fight or flight. There needs to be this oscillation between intentional stress, intentional exposure, and intentional relaxation to reset that nervous system, reset the body in order to build up that reserve to re-engage in some hard work later on again. Sensory integration is another huge component that we do here at Mountain Valley. Sensory assessments, doing a sensory profile, giving someone the language and the granularity to be able to understand how their sensory system operates. Talking about sensory-based strategies, because sometimes you don't want you taking a test to be an exposure. You want to actually feel good going into the test, or you want to be able to reach for something within the test to be able to decrease your anxiety. Sometimes you do want it to be an exposure, but sometimes there's real performance concerns on the line and you really want to be able to engage. So how do we give kids sort of strategies that can help them regulate their nervous systems so they can participate? And of course, when we're talking about sensory integration, we mentioned this earlier, that interoceptive component. And then the final piece that our OTs here really do on an individual level is really help out with the transition and discharge process. Like, what exactly does the environment and the space need to look like for this kid going forward? How do they create their own milieu at home? We have this beautiful opportunity here at Mountain Valley to intentionally design how the kids' daily routine and their habits are put together. But what is the milieu going to look like in between the different exposures that you experience? And that's where I think being in a residential setting, it makes it so much easier to do some of this exposure work than an outpatient setting, because the kid may be coming to the office and approaching their fears with you there, but then once they leave, what's the work look like in between the sessions? And how do we maintain a healthy level of participation between those sessions? And can we give some accommodation in order to just keep the positive momentum of participation going? Like, sometimes that is actually therapeutically indicated to, I'm not going to accommodate when we're intentionally doing our 1 hour exposure session in our therapy office, but when it comes to then re-engaging in the milieu, I will accommodate, because I just want you to keep this positive momentum and get this positive benefit of what it's like to participate in life again, and what it's like to be around people, and what it's like to develop competence and confidence in yourself. So that's in a nutshell, some of the different ways that OT really fits into the ERP process here.
I was just thinking, Zach, too, with the sensory integration piece, and we'll talk about this a little bit more, but you and I have worked with people who, and maybe they present with social anxiety, and they also, they're sort of hypersensitive to sounds or to other stimuli in the environment, right? And so, if you're thinking about it just from the strict exposure standpoint, it's like, well, what are we getting at? Are we getting at the social piece? Because the person can't even focus on doing the social piece because they're just so overstimulated because there's bright lights and because it's a noisy environment. So they can't even be able to start to approach that situation, right? And so I think that's where the OT can come in and provide some helpful techniques to then allow the person to also then do the other things that are more in line with the ERP work.
Yeah, thanks, Tim. Yes, I think I touched on the majority of this, but just to reiterate it, OT and ERP, that really interoceptive exposure component is definitely a huge place where we overlap. The exposure design process, so really how do we set up a meaningful and like valuable activity that's actually going to create that willingness and motivation to participate and engage? How do we reduce the other demands beyond just embracing that fear so the person can really focus on the fear component of things? And again, just really that between sessions, like what does it look like between sessions in order to really help some of this ERP, really help the ERP process sort of settle in, and how do we keep that positive momentum going? I do think it's important to highlight that like on a very basic level, there are some philosophical differences between OT and ERP, and I'll give you a chance to jump in here. But for ERP, it's really about reducing accommodation, fostering personal adaptation within the individual, not adapting or accommodating the environment for them, and really that sort of bottom-up approach. And OT is all about participation at all cost. If it's a stroke patient who lost the use of their arm, how can we get them some sort of assistive technology in order to engage in that meaningful activity that they want to do? And a lot of times, I think OTs, when they're working with anxiety, counterintuitively think, oh, how can I reduce the demands of this activity to reduce that anxiety? When really, from an ERP standpoint, that would be totally counterproductive. So OTs often look at how can we adapt the individual, how can we adapt the environment or the activity. There's sort of those three different points that we can adapt. Whereas ERP is looking much more at, no, we're looking at that individual adaptation to fear and to anxiety. But in the heart of the both of them is engagement in a valued life. And that's where we have a lot of common overlap. And a lot of times, this is one example, but for me, many times in my life, two things that are opposite actually aren't mutually exclusive. They should be included in the same thing. And they're often, when you can access two things that are opposite, that seemingly oppose one another and make them harmonious, something really powerful happens. And I sort of think that that's what we've caught on to here with the OT and ERP thing, where they almost seem counterintuitive to one another. But when you can find a way to make them synergistic, the results can be really profound.
Yeah, and I think I've always been drawn to sort of the middle ground of things, which I think makes sense, especially with the idea of this Venn diagram and engagement in a valued life. That has a different meaning for everybody with whom we work, and so if we approach each person as this sort of an experiment, there's like an N of one. What's gonna work for them, right? And for a lot of people, they find, well, it's a combination of ERP and it's a combination of the OT. Right. And even if you're looking at, I talked earlier about the cognitive behavioral therapy, you can, our clients are pulling from, well, I really resonate with acceptance and commitment therapy. I really resonate with DBT. I really love the ERP work. Right. And so there's all these different things that people can pull from. And I think, as an organization, as a program, we really try to incorporate all of those. But especially the ERP and the OT work. So I was actually thinking about, we recently had a graduation, someone who left our program, and I was just thinking about some of the ways that ERP and OT were integrated. And this was someone who came in who, Zach, we were actually just talking about someone who came in who, just being in this environment here was having, just very physical reactions to just being here, to not having sort of the avoidant coping strategies that they previously had access to. Someone with very severe anxiety and OCD, but also someone with so many strengths, right? And I think maybe Zach, you could talk a little bit about some of the OT work that you did, and I can jump in on some of the ERP stuff that we focused on.
Yeah. For this individual, I mean, one of the biggest things was like we couldn't even get to the point where we were sort of processing some of what the fear was or what was going on internally, because they couldn't access the verbal components of therapy, because the anxiety was so high, because the intrusive thoughts were so intense. And what we really needed to do was provide some sensory-based strategies to really help regulate that nervous system so we could begin to have some communication and dialogue about what was actually going on internally. And so that person could actually feel comfortable enough to go internally. So to get a little bit more practical, it was things like rocking chairs, weighted blankets, other areas that sort of tapped into the proprioceptive and vestibular system in a way that could help calm and regulate the nervous system, so that individual could be like, oh, wow, I'm experiencing intrusive thoughts, or like, I'm actually really fearful about this. And they were able to start to put some words to their experience to where we could really understand where to take the ERP process.
And I think that's so key, because you're talking about when sometimes when people come in, they're in such a heightened state of anxiety, they're really not very verbal. Like, they can't be, because that thinking part of the brain is kind of shut down, because you're just in, it's, I think of some of the residents we've worked with who come in and they sort of have a deer in the headlights look. They're literally just frozen with fear. So they can't verbalize it, they can't articulate it, or they can't enunciate it until they start to get the physical sensation, like the physiological, under control. And I think that's where OT has been incredibly effective in, I think, really moving the dial a lot quicker than sort of just waiting over time for someone to kind of habituate to the setting. And then in terms of, once you're able to get the person more regulated, and to understand some of these, what I'd say are more adaptive coping strategies and skills, then you can actually start doing some of that exposure work in a more intentional way. A person can actually share what it is that that creates the anxiety for them, or the distress. They can share where they want to be going. They can identify what is a valued life for them, right? And then they can start working on it. So if it's perfectionism related, we can start doing that work. And then we can start incorporating some of the OT work ahead of time to help someone to get into a better place, so that they can still be thinking as they're going through the exposure work, right? We can choose intentionally to add or subtract accommodations as we see fit, and not just in a this is a one-time exposure work and we're just going to accommodate, or we're not going to. But it's more like, if we are working with someone over a period of time, we can have a strategy where we say, we're going to accommodate earlier on. Just as with traditional exposure work, you're starting gradually and working your way up. I didn't really talk before about an exposure hierarchy, but that's the sense. Like, you can identify different situations that are going to provoke anxiety at what you think is a lower level and a higher level. You can take that strategy, you can incorporate supports, you can incorporate accommodations as needed, and then you can pull them back as you get further along in treatment.
Yeah, and with that specific individual too, I remember when they got here, they were very hyper focused on the schoolwork and needing to keep up with school, and it was very much their OCD. And we hadn't really had time to figure out how their OCD was manifesting in school. And they were asking, like, I want to start my schoolwork now, or I'm leaving the program, right? And like, that's where it's like, okay, like, I'm going to accommodate and allow you to engage in the schoolwork that you don't even really need to be doing. And it's really just your OCD telling you you need to be doing it, just to help you feel safe, to start to be trusted. And that activity of doing school was such a valued and meaningful activity for the individual that it was more important to just get them to participate in something that gave their life some meaning than it was to try to tell them they can't because they're not ready yet, because they haven't sort of understood the ERP process and how to not engage in certain compulsions while they're doing it. Like, it's better to have them engage with it and be doing compulsions in order to give them some of that sense of satisfaction while we continue to provide that psycho ed and do that motivational interviewing on the individual sessions in the background, so that they can come to the conclusion of, oh, wow, I don't need to be doing my schoolwork. That's just the OCD that's telling me that. But how do we kind of hold both things at the same time? I think is a really important question for all of us to ask ourselves.
Yeah. And I think looking at it again, and that it's a long game, right? And so coming up with the strategy that works for that, and yeah, helps someone who comes in feeling very scared to start to build some trust and rapport, and to see that, all right, people with whom I'm working, they're starting to understand me, right? And so I'll take some risks with them.
Mm-hmm.
I wonder if we'd like to open it up to if there are any questions or comments.
And if you do have a question, if you want to just put it right in the Q&A function, then we can pull it up.
Well, it looks like we said all the things.
I was just going to say, while we're waiting for questions to come through, I guess any kind of last thoughts from either of you on the integration and kind of what makes it so unique at Mountain Valley?
One of the things I was saying actually is that I think a lot of places are not really incorporating this. I'm not just saying that, but there's a few other places that I know of that are really intentionally incorporating the OT and exposure work together. I think, and even my experience with the occupational therapy in the past it's been more siloed, right? And I've often been in schools, and it definitely seemed more that's a department there, and here's a department over here. And I think, I'd like to see more of this integration happen sort of throughout mental health, because I think it can really accelerate and be useful for our clients.
Okay. All right, we've got a question for you. Are there other lifestyle recommendations to help regulate NS? Rocking chairs, weighted blankets, nutrition, regular exercise, ... others?
Yeah, I can go over a few different ones. So, and I'm hoping to actually have a subsequent webinar where we can dive a little bit more into OT, because I know that that's a little bit less familiar for some people. We can get into the sensory system a little bit and talk about some of that different stuff. But so weighted blankets is one example of a type of sensory input called proprioception. And you can get that in a couple of different ways. So anything that's sort of weighted and resistance oriented can be really helpful. So whether it's going to the gym and actually working out, or even just doing what we like to call heavy work in OT, pushing a wheelbarrow full of mulch, shoveling, different things along those lines that really engage the joints and the muscles, tend to be really relaxing to the nervous system. Another area that's really helpful for a lot of people is oral input. So a lot of us are oral soothers, and we have been since we were babies, and it's sort of hardwired into our nervous system from breastfeeding to using binkies to the common, I think nowadays with the vaping craze. I mean, I think a lot of it is somewhat related to the substance, but I think a lot of it is actually related to this need for oral fixation that a lot of human beings naturally have. Excessive eating is another common way that you see that happen. So ways to in which engage the mouth in a more practical way through mints, through gum, through different things along those lines can be really helpful. And then one of the other final pieces that I was talking about with the rocking chairs, that sensory system that I'm talking about there is vestibular input. So it's not just rocking chairs, it's anything that provides sort of that soothing rocking motion. So it could be a swing, it could be a hammock, it could be going for a drive, and sort of get the vestibular input of all the stuff moving past you. A lot of people find it driving very relaxing. So those are some very tangible things. And then one thing we do here a lot at Mountain Valley is ice baths. So ice baths are super good for regulating the nervous system and actually retraining the nervous system on how to self-regulate itself. And it's actually your body sort of has this counterintuitive response that when it steps into a really stressful environment, like a really cold tub, it actually decreases your heart rate, it decreases your blood pressure, it increases dopamine, it increases serotonin, and it creates this really, really relaxed feeling. Once you sort of ride that initial wave of sympathetic arousal, you go much further into a plummet of parasympathetic arousal. So things like cold showers or a 2-minute to 5-minute ice bath can be really, really impactful for people.
And I think doing that, incorporating certain ways of breathing as well. That's another thing that I think, Zach, you've kind of helped incorporate more into the community here as well, or beyond just the basics of diaphragmatic breathing.
Mm.
Great. All right, next question. Was MVTC created with OT as foundational from the start? If not, when and how was it incorporated? Are there other residentials that you know of that have OT as foundational alongside more traditional psychotherapies?
I'll let you take that, Tim, just because you've been here for a little bit longer, so you may be more in touch with where the foundation came from.
Yeah, I think the foundation for Mountain Valley was more on how do we work to really focus on anxiety and OCD, with the emphasis really being on cognitive behavioral therapy and exposure therapy. We didn't really tap into the OT world until just a few years ago, Zach, when you and Kevy came on board. So that's sort of more recent for us. In terms of other places that are doing it, I believe maybe Shepherd Pratt is doing some. I know that because I was just talking to one of their people there. So I think they are using OT and they seemed excited about it. And like I said before, I'd love to hear that, more places are starting to incorporate that just because of the results that we're seeing.
Mm-hmm. I think a lot of psychiatric settings, since sort of the boom of milieu therapy and the start of OT in the early 1900s, use activities as a part of their programming. So I think in a lot of ways, Mountain Valley probably had the activity-based component and that experiential-based component, as many good programs do. I think what has sort of shifted a little bit is this push towards functionality and not just the reduction of symptoms that can really sort of happen in the field of psychotherapy, where it's not about just reducing your anxiety, it's about reducing your anxiety so you can do your life. And it's not just about tracking whether or not, like, what's the use if your anxiety has lessened if you haven't actually learned how to participate in school, right? So how do we actually take it to that next level of functionality? Which I think OT has just really come in and helped enhance that. Like, I think Mountain Valley was doing really good work at reducing anxiety, and now OT has really come in and been like, but why? So you can do these things in your life. And how do we actually look at somebody from what do we want them to be able to do, not what do we want them to feel less or fear less?
Great. All right, we do have a couple more questions that I just want to remind everyone, in case anyone has to hop off now, that we will be sending an email out this afternoon with instructions to receive the certificate for the CEU for this. So just want to send that out. So look out for that this afternoon. Okay, next question. And actually, this is our last question. We can wrap it up. How do you know or identify which OTs are specialized working with OCD? My understanding is that's not one area, especially ERP related to OCDs, that OTs usually train on.
Yeah, that's a really good question. I mean, I'll be the first to say that as a profession, we've become a jack of all trades, which sometimes makes it hard to understand where we fit in. And it's created some inconsistency in the different OT educations that are provided in the different programs across the country. I was fortunate enough to go to school at a program where there was a huge mental health component. There was a whole 6-month in-depth about OT, mental health. That's where we started. That's where the roots are. In other countries, OTs primarily work in mental health. I think in Israel, 90% of OTs are mental health OTs. In the UK, it's over 50% of OTs are mental health OTs. In the United States, it's where it kind of got a little bit diluted. but tapping into specific OT programs that'll have a mental health focus, I think, is really important. Sacred Heart was the program that I went to. I also had the privilege of going to UNC Chapel Hill for a post master's fellowship program. They have a very heavy emphasis on mental health OT. I know Duke just started a new OTD program. They're very heavy on the mental health component. So there's just certain programs out there that really help prepare OTs to step into the mental health space. But I promise you that they're out there. And if you post a job for an OT within your mental health setting, whether it's an institution, whether it's a private practice, you're going to get a bunch of seagulls flocking to that, a bunch of OT seagulls flocking to that, because there's a lot of us out there that have sort of been cast out of the mental health world. They're looking for our entryway back in. And I'm so blessed and thankful that Mountain Valley was able to hear me out and hear my pitch for what I could do and what I could bring to the program, and allowed me to do that. But there's a lot more of us out there who want to get re-engaged. You just kind of have to go looking.
All right. Well, thank you, Zach, and thank you, Tim, so much for a really fantastic presentation. And thank you, everyone, for joining. So look out for that email later on this afternoon with the info on getting your certificate. And thanks again for joining us this afternoon.
Hi, everybody. Thank you.
Everyone.